So thank you very much for the kind invitation to OcuMel. So I'm going to talk about something a bit different, really. My main area of interest is metabolism. So, if you hear the word metabolism, you think about diet, energy, and that side of the thing. So really, the way we try and tackle cancer is from many different angles. You've probably not everybody here has seen this research wheel, but this is what we use in the lab and also in the clinic to understand the treatments that we have for cancer. So basically, we try and find ways of switching cancer signals to grow off or put back brakes on the tumor cells so the tumor's not growing. Try and find ways of boosting the immune system, trying to find ways of switching it back on clocks. We age, so we should be able to make cancer cells age and basically die. Ways of removing inflammation in cancer, which is known to make cancers grow more, stopping cancer cells from invading and spreading, removing the blood supply from cancer cells. Blood is feeding the tumor with various nutrients, so if you can remove the blood vessels, that's one way that we've been looking at that over the last few decades. And then various other ways of looking at, so chemotherapy works in this sort of area, really to try and make the tumor cells self-destruct. But one way that sort of we forgot about, but actually is quite an old way, is to remove the nutrition from cancer cells. And this is an area that's coming back, just as immunotherapy, which we'll hear about later from Professor Ottensmeyer, is also undergoing a renaissance. So probably the best example, and some of you in the room may have had one of these scans, a PET scan. This really shows you how tumor cells feed on sugar. They have a huge appetite, extremely hungry, sweet tooth. This PET scan shows a patient with a melanoma, and you can see all this abnormal activity here. Also where you combine the CT scan with the PET scan, very high activity in glands. Normally you would see the heart and the brain using a lot of sugar because, of course, those two organs are critically dependent on sugar. You know that if you don't have, you have a need for sugar when you're getting tired and you have your Lucozade, you suddenly, brighten up. That's your brain using sugar. But, some melanomas are very, very hungry for sugar. So what are they doing with all of this sugar? Well, obviously they're producing a quick form of energy to power their cells and to invade and spread. And this is a molecule called ATP. And in a normal cell, most cells are actually producing this ready form of usable energy called ATP. And very little of the glucose is actually being used for other reasons, for example, to make cells grow, because normal cells don't need to keep dividing. Only certain cells do, in the gut, for example. But once you've grown your arm or your leg, there needs to be a finite point where the body says, that's it, I've reached adulthood. But cancer cells, you can see, they're actually using a lot of this glucose to build new cells, building blocks, and making the volume of the cancer cell grow. So this is very interesting, and this actually underlies the fact that PET scans, the one I showed you just there, was extremely active in that patient with melanoma, because it's using this glucose to power its spreading of the tumor cells and also growing of those tumor cells. We've known for the last 10 years or so that there are some very important switches in cancer cells, and really the most important thing to remember here is this molecule complex called MTOR. And MTOR is a master switch, just like you switch on the lights in a room. This is very active in some tumor cells, and we know that there are two groups of these MTOR molecules, mTORC1 and mTORC2. And basically these drive various aspects of energy in the tumor cell, both in building tumor cells and also producing the driving energy in those tumor cells. And there are increasingly trials being developed looking at switching off some of these metabolic or energy regulators in the cell. So there are drugs that have been developed which block some aspects of this master regulator and also other signals that feed into mTOR. And I'm going to focus mostly on one particular nutrient, which also has been shown to feed this regulator mTOR, but also does a lot of other things in terms of energy production in the tumor cell. So in terms of focusing on this particular feature of cancer, so abnormal energy production and the use of molecules such as glucose and other nutrients, we've developed two trials. One is my particular area of interest, which is focusing on this one amino acid which builds proteins in the cell called arginine. I mean, you can go into the health food store and buy, basically boxes of tablets of arginine, and bodybuilders use these things. It's been sort of recommended as an amino acid for boosting immune function as well. Basically, does quite a lot of things inside the cell. And then we also have a trial focusing on that called the TRAP trial, and I'll mention that we're just about to open that also for patients with metastatic uveal melanoma. And the second trial, which is currently running, is a trial looking at another one of these blockers of the molecule mTOR, which is this master switch in terms of energy production in tumor cells. So the basic concept is very simple. You have a tumor cell, in this case, it could be the uveal melanoma cell, and it basically loses this enzyme called ASS1. It's a bit of a, difficult name for an enzyme, AS1 or ASS1. But basically, if the tumor cell doesn't have this enzyme which makes arginine, it needs to feed on arginine from the blood. That's the only way it can survive. If you remove the arginine from the blood, and there are various ways of doing that, this is an enzyme drug which is given as an injection in the muscle in the bottom or in the arm, you basically deprive that tumor cell, you starve it of arginine, and it can't grow, so it basically dies. And this is something that currently is in clinical trial, but in fact the proof of principle has been shown several decades ago in childhood leukemia. You may have heard of acute lymphoblastic leukemia, one of the commonest leukemias in children, and 60, 70 years ago, only 5% of children survived 5 years with this disease. Now the cure rate is 90% plus 5 years in these children. One of the drugs that has been important in the use of, in a combination, in a cocktail of chemotherapy drugs, is an enzyme which removes another amino acid called asparagine. So if you like asparagus is full of asparagine. And again, some of these leukemia cells have a particular love of this amino acid, asparagine. And using this drug in children, you can remove the asparagine. And again, it doesn't have the enzyme to make it, so therefore the leukemia cell dies. So, it's a very old concept, but as we learn in research, we're always refinding things to work on. So I mentioned arginine is the area that we're focusing on. It does a lot of things in tumor cells. There are about 20 different amino acids in your diet that you need, that you have in your diet. 10 of those are essential, so you can't get them from any other means except your diet. The other 10, they're actually dispensable, which means you can actually make them from other amino acids and other chemicals in your body. You have these enzymes, such as ASS1, which basically acts here, and this enzyme makes the arginine. So in fact, you can go on an arginine-free diet today, and you'll be absolutely fine, although you won't like the taste of an arginine-free diet, but certainly it won't harm you in any particular way. But some tumor cells, they need the arginine from the blood because they don't have this enzyme, and the arginine is being used for all sorts of things. So not only is it being used for proteins building the cancer cell, it's also being used to, in this case, to make some DNA molecules, the instruction for growth. It's also used to make other amino acids, and also you may have heard of this molecule nitric oxide, which does a lot of things in both normal and cancer cells, including regulating your blood pressure. So a number of studies have been done with one of these arginine blockers, and they focused really on liver cancer initially and also on melanoma. A number of studies have been published now, and interesting response rates. just by removing this one amino acid, there's evidence of control. Also, looking on a PET scan, you see reduction, in some of the patients on a PET scan. So 25% in this study from Memorial Sloan Kettering, reduction in signal in patients with melanoma. And actually, very interestingly, the most significant signal in that study, which was published 2 years ago, was in patients with advanced metastatic uveal melanoma, not really the cutaneous or the skin melanoma in that group. But interestingly, of note, both the patients that had stable disease for more than 6 months and 4 out of the 9 patients that had stable disease in total, it was a small study, were actually patients who had uveal melanoma. And the other important thing to point out is that the median time to when the patient progressed on the scan was 57 days, but in uveal melanoma was 113 days. And I think the longest patient that had stable disease with uveal melanoma, as pointed out there, was 337 days, which, considering many of our current drugs still do not achieve stable disease for more than 2 months in general for patients. So, and this is just removing one nutrient from the blood. So my other interest, if I'm going from here to give a talk in Sheffield later today, is actually on mesothelioma. I've been doing some clinical trials in patients with mesothelioma. And it's important to note there are some similarities between mesothelioma, some of the data I'm going to present now, and uveal melanoma. You may be aware of this gene called BAP1. There's a lot of interest in this, but it was actually first discovered and described in patients with eye melanoma. And then a year later, there was a publication in a prestigious journal also pointing out these rare families in the US where there was no asbestos exposure, which we know is the link for mesothelioma. And you can see a lot of these family members developed cancers. The 2 commonest ones were patients who had uveal melanoma and mesothelioma. So I'll come back to that link towards the end. So this is the work we did in the lab to show in patients with mesothelioma using cell lines that removing arginine could actually be effective in the Petri dish. So you can see we looked at a panel of various mesothelioma cell lines. Half of them had completely lost the signal for this enzyme called ASS1 or AS. So we then took 2 cell lines, one that had lots of this enzyme AS, so therefore this is one that makes its own arginine, and one that completely lacked this enzyme, and just wanted to see what happens if you remove arginine from the tissue medium that was being fed to these tumor cells. And you can see that if you remove arginine, but keep one of the other amino acids in place, only the negative cell line for this enzyme dies over a period of 9 days. Whereas the one that has lots of this enzyme is very happy. It doesn't care you've removed the arginine, it will carry on growing. So a very neat way of distinguishing between 2 different types of tumor cells with mesothelioma. And as I say, about 50% of them were sensitive to this nutritional starvation approach. And very easily, it's removing a biopsy from a patient. You can test for whether the patient has the enzyme or doesn't have the enzyme in the tumor cell. So we designed a clinical trial which completed a recruitment 2 years ago. We screened over 200 patients in the UK with mesothelioma, and if they had a tumor that didn't have this enzyme, ASS1, we then randomized them either to receive this weekly injection of this arginine blocker, or they had best supportive care. And it was a very flexible design, so patients didn't have to have chemotherapy to go on this study. We also took patients who had previous lines of chemotherapy. And really, we just wanted to see in this study whether we could see any signal that removing arginine from the patient's blood could control the mesothelioma. The drug was really very safe. We had a few patients who developed low blood counts, but nobody actually developed an infection on the treatment. There were some patients who developed an allergic reaction because the drug is actually made from a bug, so it's a foreign protein. So just like you can get an allergy to peanuts, you can develop an allergy to this drug. But generally, it was very well tolerated, and we saw evidence on PET scan of the sugar uptake going down So we were having an effect on the metabolism, on the energy supplied to these tumor cells, and that was actually in just under 50% of patients we saw this significant reduction. And this is the key slide from that trial, which we're due to submit for publication. Presented it last year at one of the big cancer meetings in the US. But we had basically a 50% prolongation of patients with disease who had disease control on the study. You know, that might not seem a lot to you, just under 40 days stable disease, but in fact the previous drug that had been looked at in a big study of 600 patients that was published last year, there was an improvement, but only in 36 hours, statistically significant disease control for 36 hours. So we've, in this study, shown a 40-day stabilization. And, very interestingly, our cutoff for this study, because we do see some tumor cells that have negative and positive cells, what we call, a mixed phenotype or a mixed picture, whereas some patients had completely negative tumors for the enzyme. So if you divide patients into those who had less or more negative cells for this enzyme, the patients whose tumors were more negative for this enzyme actually had much better disease control than those who had less of the lower amount of enzyme. So we've looked at this recently in the laboratory using some Uveal melanoma cell lines kindly gifted by Professor Copeland from Liverpool. And basically, very small number of cell lines. We looked at 3 of these uveal melanoma cell lines, and all 3 were completely negative for the enzyme. So you think these should actually be very sensitive to removing arginine. So we did the same experiments in the Petri dish. We used the cell line, which is actually a skin melanoma cell line, as a control. You can see that one doesn't care if you remove arginine, continues to maintain its viability, growing in the Petri dish. But look, all 3 of the uveal melanoma cell lines over a period of 6 days had a significant reduction in their viability down to less than 20% viable cells with one of 2 of those cell lines. So we went back and looked at 100 patients who had an eye removed for a diagnosis of uveal melanoma. So this is primary eye melanoma tissue, and you can see this is one of the very few cases that we found that was positive. So unlike in our mesothelioma patients, where about 40% have significant loss or deficiency of this enzyme, the majority of cases, so 75% in this study had very low levels of arginine, or completely absent. So this is completely absent enzyme. So we think that this tumor probably is a very good target for this nutritional approach, removing arginine, and was one of the reasons for moving further into the trial development. So, we got that signal in the patients in the mesothelioma study, and in fact in the laboratory a lot of people are working now in this area of metabolism, and various groups around the world have looked at combining drugs that remove arginine. So another enzyme is called arginase, or the one we use is ADI-PEG20. And several of these studies have shown that you get better tumor control in the laboratory, both, and these are actually in animal studies showing if you combine these drugs with chemotherapy, you get even better results, or with more targeted type drugs. So this was a so-called PI3 kinase inhibitor. So based on that, we went back to the laboratory to see, what was happening when we removed arginine from these tumor cells. This is actually some studies done in mesothelioma cell lines. We've also done this in bladder cell lines. We're still working on this in uveal cell lines. But basically, we showed that when you remove arginine, you have a very profound effect on the enzymes that make DNA. So one of these is called TS. But essentially, we are impacting DNA synthesis. So not only are you removing an amino acid that builds proteins, you're actually having a downstream effect on DNA production in the tumor cell. And generally, that would be considered a good thing. A lot of old chemotherapy drugs that work through blocking DNA production in tumor cells. And we found that if we combined arginine deprivation with this drug using another drug, which is a standard treatment in mesothelioma called pemetrexed, we actually get better cell killing. You get a much higher signal here when you use both drugs together than when you use the single drugs. We've also done this in in uveal melanoma cell lines, and we also show that pemetrexed is actually active, at least in the laboratory, in uveal melanoma cell lines. We've also done this in animal studies, so you can see this was actually a bladder cell line that was very sensitive for removing arginine. If you use the drug on its own, pemetrexed, that does affect DNA, there's not really much difference in the size. You can't really see that, but the tumors get progressively smaller when you use the two drugs together, which is what we saw in the Petri dish. And this is the design of the current trial called TRAP, so stands for tumors needing arginine, to assess the role of this drug that removes arginine as a starvation treatment with two chemotherapy drugs. And this study was originally designed in patients with mesothelioma and lung cancer. And the idea is really, can we get better results by combining the drugs because we are blocking DNA production, so the actual information inside the tumor cells. And we've now completed in this what's called a phase 1 study, so we're still looking at how safe this combination is of the three drugs, and we are now at the highest dose level, and we've not seen any additional side effects to using the two chemotherapy drugs alone, where we have a lot of experience in patients with lung cancer and mesothelioma. We've done this at 3 centres in the UK, at Barts, Cambridge, and also at Guy's in London, and we've got good results, so I can't present all of them here, but we will be presenting the data at a meeting in Boston in November. Suffice it to say, we're seeing at least a doubling in the historical response rates that we would have seen. So instead of 30 to 40%, we're seeing upwards of 80% response rate in these patients. This is just one example. The first patient that we had with mesothelioma, you can see in the lung here, a significant reduction in a tumor there. So we're now expanding the trial to include additional cohorts of patients, and we're hoping that the paper will be signed off and will be open to recruitment next month. So it'll be a 10-patient study with patients with metastatic uveal melanoma, and we're also expanding that into patients with brain tumors, where there's also a big need for new drugs. There hasn't been any interesting developments in patients with brain tumors for about 20 years. Liver cancer, that particular group will be done in Asia, in Taiwan. So the criteria will be anybody can go on the trial, although they mustn't have had chemotherapy in the past. So that's one exclusion criteria. Patients who've had immunotherapy will be allowed to go on the study. And because we're giving an injection once a week, patients mustn't be on therapeutic doses of anticoagulants such as warfarin or other drugs that are used for heart disease. And patients who've been on previous studies, if they've got ongoing side effects, those must have resolved to go onto this trial. So just the last 2 slides or so. The second trial that is actually currently open for patients with a number of different cancers. It was mostly designed for breast and lung cancer patients, but patients with melanoma, all kinds of melanoma, are allowed to go onto the trial. And this is another study based on exploring can you switch off the energy supply in tumor cells by using a drug that has already been published called a MEK inhibitor. You may have heard of that. There was a publication last year from Memorial Sloan Kettering which showed using this drug controlled disease twice as long as dacarbazine, which we know probably isn't much better than best supportive care, actually. And here we're combining the MEK inhibitor with this MTOR blocker, which blocks both arms of the MTOR complex, TORC1 and TORC2. And you can see if in this lung cancer cell line, you have much better control when you use the two drugs together. And that was a paper published a few years ago in Cancer Research. You can see another cell line, lung cancer cell line, even better control, again, when you use both of these drugs, the MEK and the MTOR blocker. So we have a patient currently on this trial who's doing really well, who has failed ipilimumab, pembrolizumab, and also a third trial of a drug. The good thing about this trial is a tablet-based treatment, so it's taking 2 different tablets, and for the first time this patient has actually got shrinkage of their tumours, which may of course be the MEC on its own because that's been published, but we're exploring particularly the combination here. So that's the trial. It's taking place at Barts and also with Professor Middleton in Birmingham and Professor Schmitz at Barts. And essentially any patients with metastatic or locally advanced disease which hasn't responded to previous therapies would be eligible for this trial. And as I say, patients with melanoma can also go on to this trial. So it's still an early trial. We've only got the first 3 patients, and one of those, as I mentioned, is a patient with metastatic uveal melanoma. So in conclusion, I think it's very important to understand all aspects of cancer cell biology. Where our particular interest is in metabolism, it'd be great to switch off the lights, as I say, in cancer cells. I think, once the immune system becomes completely exhausted and patients are not all cured with immunotherapy, this might be the way, just as you would remove fuel from a car. If you remove the energy, the cancer cell can't go anywhere. It might still be there on the scan, but it's just not doing anything. So stable disease, we like stable disease. And we focus by doing that, removing arginine or blocking MTOR. I think going forwards, it's going to be very important to leverage knowledge in other cancers and also cross-fertilize data from uveal melanoma. I mean, who knows, pemetrexed may work better. There's that link with mesothelioma. It's the standard treatment for mesothelioma. And BAP1 is at least a common genetic feature in some of these tumors. And we should really encourage trial recruitment because that's the only way that we're going to solve this problem and to make progress. So thank you very much for listening, and happy to take any questions.
Thank you for that talk. It was really useful. Does anyone have any questions they'd like to ask?
It was very interesting. Thanks very much. What I was wondering as you were speaking is, wouldn't it be ideal as an adjuvant for the high-risk patients, this? Because then you'd be treating a lower burden and you might be able to prolong that time that they have in the interval.
Yeah, I think that's certainly where we want to go eventually with these treatments. I think adjuvant disease is going to be still quite a long time because it's a very tricky area. It's a relatively small, rare disease. Doing these studies requires huge numbers of patients, and I've heard drug companies are pulling out from adjuvant. I understand there was an adjuvant study with immunotherapy. Christian might know more. I understand that that has closed with ipilimumab. The costs would be enormous to find. And actually, I think we're still stuck with this imaging problem. I don't think imaging is going to be the answer. Clearly, there are lots of issues with imaging still, and we need better technology to see very, very early disease.
Yeah, the thing I was wondering about is sometimes uveal melanoma has PET negative metastasis. Yeah. Do you think that matters?
Yes, so we offer PET scans at Barts at primary diagnosis. We do offer that for everybody. You're quite right, there's quite a lot of mixed pictures or heterogeneity with glucose use, which tells you actually the tumours are probably using other fuels. Yeah. So, there's a lot of interest in other pathways and doing other types of PET scans. In fact, in our study, we're doing FLT PET scans. So we have now imaged over 10 patients where I think we've got most of the data. And we are seeing signals on the FLT within 24 hours of actually treating a patient. But that analysis is still underway. But I think that's right. In future, we'll need other traces. And again, that's expensive to do those studies. At the moment, it's all research, really. Christian.
How often can you give this inhibitor? It's immunogenic, isn't it?
It is, yeah. So it's given weekly. And there is a problem, so the arginine levels do increase back to baseline after around 2 months. In the current study, we're actually seeing that that's been extended to 3 months, so whether that's use of steroids or the chemotherapy, I don't know. That's potentially an issue, but it's also important to note that the bloods that we do for dosing are, after the 7 days has elapsed. So probably we are still seeing reductions in arginine, and it's probably oscillating, but that would need doing more bloods. That's the current view.
Because that would be important for an adjuvant study, isn't it? If you
That's right,
wanted
yeah.
to
So
continue giving it.
This would only be really in combination if you found a really successful combination.
Thank
So
you.
I think we have the debate now, is that?
We do. We're going to set the tables up. Thank you very much.